Welcome to Chapter 11. This is our chapter evaluating the pathology of the reproductive systems in both the male and female bodies. Read through the chapter objectives to get familiar with some of the things that you're going to be looking for in this particular lecture. We're going to start our lecture by looking at infectious diseases of both genders. And obviously, there's more than just syphilis and gonorrhea that are infectious diseases that can affect both genders. We also have chlamydia and a number of other sexually transmitted diseases. But because these two are the most common and have the most severe effects, we're going to look at syphilis and gonorrhea in more depth. Syphilis, as you know, is a sexually transmitted disease caused by a specific bacteria that's very difficult to pronounce. So I'm going to let you have your best whack at that. Now, babies of an infected mother can be born with congenital syphilis. So it's not always passed through sexual contact. And babies with congenital syphilis can suffer a lot of consequences due to their syphilis infection from the onset of birth. So there's 3 stages of a syphilis infection. Now that syphilis can easily be treated by penicillin, most of these infections will be identified and treated in the primary stage. Years ago, they were not treated in the primary stage, and they went on to the secondary and tertiary stage, where they went to have very real implications and negative consequences for the patient. So the primary stage of syphilis is typically where they find a sore, an open wound on the vulva of the female or on the penis of the male. If it's not treated at that point, it can go on to become a secondary infection, and the secondary infection usually results in a rash that's not necessarily concerning typically to the patient. And then the disease can actually go dormant for many, many years and then finally reappear as a tertiary or a later latent expression of the disease. And when this happens, syphilis becomes very detrimental. It can affect many different parts of the body, including mental status, in causing destruction of the eyesight, also resulting in deterioration of bones and joint spaces. So at this point, by the time it becomes tertiary, there's no cure for syphilis. So it needs to be identified in the primary and secondary forms to be adequately treated. Gonorrhea, on the other hand, is the most common bacterial STD in our current society. This is more common in males than females, and it's treated with a bacterial or an antibiotic since it has a bacterial origin. Usually treatment of or symptoms of gonorrhea would be a short time, 2 or 3 days after exposure. You would have a significant discharge, sometimes painful urination, and things like that. Okay, the physiology and the diseases of the male reproductive system. So the main function of the male reproductive system is to produce sperm for fertilization of an ova to produce offspring. And the production of sperm occurs in the testes or in the orchids, which is the medical term for testicles. Usually this process is referred to as spermatogenesis, and spermatogenesis occurs or begins occurring in males at about 13 years of age and then continues throughout the male lifespan. Unlike females, males are able to continue developing and producing sperm typically capable of reproduction throughout their whole life despite their age. The sperms then go to mature in the epididymis. So if we look at one side of what this looks like, if this is a testicle, usually it's within here that the testicle is going to produce sperm or go through spermatogenesis. Next to the testicle lies the epididymis, and the epididymis has a head at the top, a body along the side, and a tail that wraps around the bottom of the testicle. And it's within this epididymis that sperm, which is produced in the testes, moves into the epididymis for final maturation and storage. Now, upon ejaculation, the sperm comes out in what we call the Vas Deferens. And the sperm then moves through the ejaculatory duct, where it travels anterior to the bladder, over the top, and back down the posterior side of the bladder. So here would be our bladder. And when that ejaculatory duct comes behind the bladder, it is met with seminal vesicles. And these seminal vesicles are able to articulate with that ejaculatory duct and provide fructose to the sperm to maintain their energy level and for them to continue their motility up to the ova for fertilization. Now, just past the bilateral seminal vesicles, there is a bulbal urethral gland, and then the prostate, and both sides, both ejaculatory ducts will combine and go into the prostate and then dump into the urethra. At that point, the urethra extends down the penis, and then that is where the semen, which consists of the sperm as well as the seminal fluid and the prostatic juices, would all exit the male body. And at that point, the semen would have not just the sperm, but all of the nutrients and juices necessary to keep them living until they were to reach the ova. So this process will continue on, and anytime ejaculation occurs, then there would be a contraction of this whole organ system, which would then eject this sperm out so that it could go on to produce fertilization. So some of the diseases that affect specifically the male reproductive systems are really going to occur in the prostate because females do not have prostates. So these are going to be the ones that are unique to the male. So benign prostatic hyperplasia or hypertrophy, BPH, is the most common thing you'll hear about. And we'll take a little closer look at that here. So benign prostatic hyperplasia is an enlargement of the prostate gland, and it usually starts occurring in men that are over age 60. When we see BPH on a gentleman, one of the most common exams you may see this on is when you do a voiding cystourethrogram or an IVP where the bladder fills with contrast. And when we have a contrast-filled bladder that has a disruption or a deviation at the base of that bladder, that can be indicative of a benign prostatic hyperplasia. The prostate on a normal male patient with a normal prostate would have the prostate right here at the base of the bladder, but as that prostate grows and enlarges, it can compress the bladder in a nice smooth pattern. It doesn't have any specific palpable masses, it just overall enlarges. One of the main problems with this is that it can cause difficulty urination or frequent urges to urinate and incomplete emptying of the bladder. And anytime we have urine sitting in the bladder for a long period of time or stasis fluid, it's more likely to develop an infection. So BPH could cause infections eventually in these patients. Otherwise, it is a benign process. Sometimes the urinary implications for these patients are so significant, they'll do something called a Terp procedure, where this is a transurethral prostatic biopsy, or TURP. And they're able to go up, some men will call this the Roto-Rooter job, but they're able to go up that prostate that's squeezing on their urethra, and they're able to remove some of that prostatic tissue to open up the urethral space. Here's an example of the the bladder image of an IVP, and you can see that this bladder that should be filled with contrast is being displaced by a large mass, and this would be significant for BPH. Now, BPH has the tendency where it can actually turn into prostate cancer. Prostate cancer is the second most common malignancy in men, and usually it's going to occur in our older population, 15 years of age and older. However, there are some cases that there are incidents increasing about 40% with advancing age. So the older you get, the more likely you are to have prostate cancer. The prostate cancer can be really slow growing and asymptomatic, and people can actually live years with this type of cancer. Other prostate cancers can be very aggressive and spread quickly with metastasis. So it's going to be entirely dependent on the type of cancer. Here's an example of how a prostate cancer looks a little bit different than your BPH. The BPH had a nice, smooth, rounded, enlarged border. And you can see this patient here with the prostate cancer has more of a lobulated nodule type appearance. That would be indicative of prostate cancer. One of the ways that prostate cancer can be identified is through transrectal ultrasound. So with the transrectal ultrasound, you use a vaginal type ultrasound probe, insert it into the male's rectum, and it gets you very close to the prostate. And from that, you can evaluate the prostate, soft tissue differences, and look for any changes in texture or lobulation that might indicate that there could be prostatic cancer. Usually, ultrasound is not very specific when it comes to identification of prostate cancer, so lots of times it will require a biopsy to determine the origin of whether the enlargement is due to BPH or prostate cancer, or perhaps just a benign mass. Here you can see on this MRI, here is an enlarged prostate, and it has a darkening in this central area indicating that there is a mass there. In this case, it ends up to be prostate cancer. With prostate cancer, they can do a blood test called the PSA, or prostate antigen specific antibody. And prostate specific antigen is going to indicate higher levels can indicate the higher probability of prostate cancer. Unfortunately, it's not specific only to prostate cancer, so sometimes you'll see an elevated PSA even with your benign prostate hypertrophy. So it's not clearly tied directly to cancer, but it can be used as a good screening test to point a physician to look at a male's prostate more in depth. If it's a low-risk male, lots of times their prostate will be examined by a digital exam or a finger exam, where the physician advances the finger up the rectum, is able to apply pressure to the prostate, and these nodules associated with prostate cancer can feel firm and cause alarm, or for the physician to go on to the next stage of testing. Crypt orchidism is typically identified in newborns. So crypt orchidism is the process where the testes of a male fetus or a male infant have not descended from their abdomen to their final placement in the scrotal sac. And so this can also be called undescended testes. It's more common in premature males. It has a couple risks associated with. So, the testes really develop inside the fetus's abdomen and then descend over time, and they should be in the scrotal sac later in pregnancy before delivery. And that's one of the things pediatricians are really good about checking on male infants, is to ensure that their testes are truly within the testicular sac, or excuse me, the scrotal sac. If they don't, you can usually identify them somewhere in the infant's abdomen. So that can be done by ultrasound or by MRI, and the testes can be identified, and then it can be surgically removed, or they can try to move it into the scrotal sac. Now, the problem with leaving a undescended testis in place is that it can cause infertility, because for multiple reasons, but one of which would be the heat of having that testicle within the body would make it malfunction. The other thing is that because of that excess heat it's exposed to, these undescended testes are much more likely to turn cancerous at some point. Now, one of the reasons the testes are in a scrotal sac is because that scrotal sac is able to contract and bring the testicles close to the body to keep them warm when it's cold outside, and they're able to relax the testes away from the body to keep them cooler when the body is too hot. So the scrotal sac itself is the testes' way of temperature regulation. So having crypt orchidism or an undescended testes removes that option for these testicles. Here's an example of this little testes. These will usually they will descend from their development in the pelvic region down to their position in the testes through the inguinal canal. So if you suspect cryptorchidism, you're going to be looking somewhere in that inguinal canal to find that undescended testes. Testicular torsion is the complete or partial torsion of the vessels and nerves of the testicle. It usually occurs when there's a twisting of the gonad on its pedicle or on the spermatic cord. And this leads to compromise of the circulation and sudden onset of severe scrotal pain. It can often be caused in young men, especially active, after some sort of accident or after some significant physical activity. So what happens is we have all the vessels that feed the testicle coming down through the inguinal canal as part of this spermatic cord, and then the testicles and the epididymis are at the bottom of that cord. So with extreme activity, sometimes these vessels can turn on themselves, and when a vessel does that, it kind of acts as a twisted hose. So if I have an artery that's coming through and a vein that's coming through and they twist upon themselves, it would cut off the venous supply usually first because the vein is much softer than the artery, and if the torsion was significant enough, it would crimp off the arterial supply as well. Doppler and nuclear medicine studies are really good at evaluating testicular torsion. Patients with testicular torsion are in extreme pain. If they have no venous flow, but they still maintain arterial flow, they're going to be pumping blood into the testes, but that venous blood can't get out and the testicle will become very swollen. With this, because it's going to affect the vascularity of the testes, time that it takes to get that patient to surgery can affect the viability of returning that testicle to normal. Now, again, testicular torsion is commonly thought of as the complete obstruction of vasculature to the testicle, but even just the obstruction of the venous vasculature would count as testicular torsion and need to be addressed immediately by surgery. These patients are in extreme pain, often with nausea and vomiting, and need help immediately. Here's an example of an ultrasound of testicular torsion. This testicle on the left demonstrates blood flow. You can see as the bright colors here, and is nice and normal inside. This testicle on the right is grossly enlarged and demonstrates no blood vascularity. So this would be a complete torsion, it appears, of the artery and the vein. This is an example of a torsed testicle on nuclear medicine. Epididymitis is inflammation of the epididymis, and as you remember, the testicle sits here and the epididymis kind of wraps around it like a little worm. Epididymitis is inflammation of the epididymis. It can show some pain. It can cause swelling of the epididymis, which a male may feel as a lump. Doppler ultrasound with epididymitis would demonstrate increased blood flow. Nuclear medicine would indicate increased radioisotope uptake. And that's because if you think about what itis is, it's an inflammation, and inflammation draws in additional vascularity to provide white blood cells to attack this inflamed area. So because of that, the vascularity would increase so that the immune process or immune response could attack the inflammation. Here's an example of epididymitis on a nuclear medicine study, and you see this greater uptake in this area would indicate epididymitis of that area, that general epididymis. Testicular tumors are most common in younger men. So usually we'll see these originate in men at about 20 to 35 years of age. Often they'll have no signs or symptoms that there's an issue and find these incidentally. Almost all intratesticular tumors are malignant. So if something is visualized within the testy itself, not in the epididymis, not in around the testy, but if it's within the testicle, it has a very, very, very high probability that it's a malignant tumor. The malignancies of the testicles will often metastasize through lymphatic spread relatively quickly. Some of the major tumor types are seminomas and non-seminomas. Now, seminomas are tumors of the sperm cells. Non-seminomas are known as teratomas or other germ cell tumors. These are something that you can also hear called as a dermoid cyst sometimes, and basically they originate when a person is developing from fertilization forward. All of our cells come off of one of three germ cell layers: the endoderm, ectoderm, and mesoderm. So each of us in our very most beginning form will have three germ cell layers: endoderm, ectoderm, mesoderm. Now, those germ cell layers are incredibly important when it goes on to producing offspring. So in the testes, where they're developing sperm, and that sperm is going to take its chromosomal information to produce offspring, there's going to be a lot of germ cells located in the testicle. Now, sometimes these germ cells can begin growing awry, and we know that each layer of germ cell is capable of producing a number of different tissue types. So these teratomas can develop when these germ cells start growing out of control, and they can produce tissues of varying types such as fat. They can grow teeth, they can grow thyroid tissue, they can grow hair, they can grow bone, and they're very interesting, sometimes scary little tumors. So non-seminomas include teratomas and other germ cell tumors that originate off of one of these three original germ cell layers. These are often diagnosed with ultrasound because of the non-ionizing approach and the low cost. Here's an example of an intertesticular tumor. So you see that on ultrasound, this is the testicle itself. And this is certainly an intertesticular mass. So it has a high probability of malignancy, and upon biopsy, this one turned out to be a seminoma. Here's a teratoma. This is a pretty simplified teratoma. Sometimes these get much, much uglier, but you can see this mass has mixed tissue characteristics. So there's some solid components, there's some fluid components here in the black, there's some calcified components. Lots of these will also have fat and hair and teeth and a number of different other things. This particular one is relatively simple. So which of the pathology of the male reproductive system demonstrates Doppler ultrasound with a decreased blood supply? That is going to be your testicular torsion. Okay, physiology and diseases of the female reproductive system. Female reproductive physiology: the ovaries produce the ova go into the fallopian tubes, they travel down the fallopian tubes. If they are fertilized before they get to the uterus, then they will try to implant in the uterus. If no fertilization occurs, then they just simply travel through the uterus, out the cervix and vagina, and are eliminated. Unlike males who produce about 5 million spermatozoa per milliliter of semen, women only produce 1 ova a month typically. The ovaries are a very unique organ, and they are because they don't only serve as a gonad, producing and maturing ova, preparing them for ovulation. They also release a number of different hormones. So the ovaries are considered a gonad as well as an endocrine gland. So menarche, or this is the terminology for menstruation, menarche begins usually between ages 11 and 15 years of age. And when menarche begins, that's when the female would be fertile, because menarche begins when the ovary begins releasing ova. Once a month, as long as everything in the menstrual cycle goes as it should, one ova should be released from one or the other ovaries. It's very unlikely or unusual that both ovaries would produce an ova in the same month. Ovulation occurs about 14 days after the first day of a menstrual period. And that an ovulation is the expulsion of the ova into the pelvic cavity, where it should be picked up by the fallopian tubes and begin its descent towards the uterus. One of the significant problems or pathologies of the female genital system is pelvic inflammatory disease. Pelvic inflammatory disease is almost always caused by an STD in the lower genital tract that moves up the genital tract from, say, the vagina to the cervix to the uterus, out the fallopian tubes and into the peritoneal cavity around the ovaries. So pelvic inflammatory disease is usually some sort of infection that has basically gone out of control. Most often it's gonorrhea that can cause this. Women that are young age, more sexually active, starting sexual activity at a younger age, all of those put women at a greater risk for pelvic inflammatory disease. Having had pelvic inflammatory disease will put a woman at a much higher risk of having infertility or having ectopic pregnancies. It can increase her chance of having infertility. One pelvic inflammatory disease process can increase her chance of infertility 8 times. Having pelvic inflammatory disease 2 times can increase her risk of infertility 18 times. So again, you're going to see women that are most likely in their sexual activity years between ages 15 to 18, 20 to 24, that's going to be when you see the most pelvic inflammatory disease, which can have very long-term effects on the patient. Now, it is important to note that it's not just, while it's typically from STD, it can be caused by other sort of insults to the pelvis as well. So sometimes an unsterile abortion, things like instrumentation or a DNC can cause pelvic inflammatory disease. A retained tampon that hasn't been removed can cause it, and other types of infections. So it is important to remember that this can affect other people besides just the STD component. But the repercussions of PID are extremely negative for patients when they get to the trying to reproduce or have offspring. Okay, other things that are unique to the female genital system is going to be ovarian cysts and tumors. A type of this is the dermoid cyst or a teratoma, which is one of those germ cell cysts like we just talked about. Another thing that affects them is uterine fibroids, endometrial carcinoma, endometriosis, and carcinoma of the cervix. And we'll look at all of these. Ovarian cysts are pretty common cysts. They're usually well contained, fluid-filled structures within the ovaries. Some of these are simply follicles that developed with the ova in them but never ruptured, causing ovulation, and so they continue to get larger and a little bit larger and stay on the ovary until eventually they rupture. Once a cyst ruptures and releases the ova, it kind of implodes on itself, and at that point it becomes a corpus luteum cyst. And so what happens with the corpus luteum cyst is that the follicle ruptures, it releases the ova, the follicle implodes on itself, and then it actually produces a bunch of progesterone to prepare the endometrial canal for implantation of an embryo. If that corpus luteum maintains and doesn't resolve after about 10 or 14 days, then it's called a corpus luteal cyst. Another abnormality is polycystic ovarian syndrome, and this is a very complex endocrine related process that is often associated with diabetes mellitus or type 2 diabetes. So with polycystic ovarian syndrome, the ovaries end up developing a bunch of different follicles on both ovaries, and ovaries can get very, very large. But because of some abnormalities in hormonal levels, they never actually end up ovulating. So these patients with PCOS will have difficulties with the infertility. The other thing is they often have some androgen hormone effects. And androgens, like we know from the last chapter, are the male hormones. So sometimes the hormones that are produced start out as androgens, get converted to an estrogen, and then processed by the female body. In PCOS, sometimes that conversion to estrogen doesn't occur, and these females will start taking on hirsutism characteristics. And hirsutism characteristics are those male characteristics. So it can be rounding of the face, acne, facial hair, loss of hair on their head, more fat in the abdominal area, things like this. It's considered the most common genital disorder found in young women and can have very devastating complications for them. And so it needs to be evaluated on an endocrine level to determine how to help correct this issue. Here's just a plain ovarian cyst on an ultrasound. Here's the ovary. This large area that we would say is anechoic or black is just a fluid collection, and it's well defined, and that would be classified as. So the most common primary malignancy, like I said, is cystenal carcinoma. And these cystenal carcinomas, there's multiple different types, but they're going to appear as a very large cystic mass with internal septa. They're going to have a lot of blood flow, and they can be very difficult to tell apart from their benign counterpart, the cystadenoma. And there can be a couple different types. There can be mucinous cystadenomas or serous cystadenomas, or the serous cystenal carcinomas or mucinous cystenal carcinomas. And obviously the carcinomas are going to be malignant, where the adenomas are going to be benign. The more solid and irregular the mass is, the more indicative it is that it's probably a malignant tumor, but without biopsy, it will be difficult to know for sure. Here's an example of an ultrasound of a primary cystadenal This whole area here contains some cystic components or fluid components, which you see as this anechoic or black structure, as well as some irregular papillary type solid component projections. If you were to look at this with blood flow, it would be highly vascular, and upon biopsy or removal, they would identify that this is a cystadenal carcinoma. Here's another example where, again, you can make out this mass. It has some solid components that you see as these low-level gray areas, as well as some cystic or fluid-filled components, and then septations working their way through those cystic components. This one could be benign. It could be malignant. Until they take a biopsy, they won't know. This one turned out to be benign, because it's a cystadenoma instead of carcinoma. And that would be indicated partially through this ultrasound because it has these smooth walls, unlike the last image we saw. But again, there would be no guarantee until they did a biopsy. Now, a dermoid cyst is really similar to the seminoma that we looked at with the male system. So again, we know that our ovaries are gonads. They produce ova, which go to produce our offspring. And so in those ovaries, we must contain germ cells. Those germ cells are those three germ cell layers, endoderm, ectoderm, mesoderm. And because those three germ cell layers that can produce any tissue in the whole body exist right there in the ovary, they can actually become active, start to produce different tissue types, and they can produce a mass called a dermoid cyst or a teratoma. And that cyst can contain hair, skin, teeth, nails, fatty elements, all kinds of disgusting things. Usually these are benign. However, they do have the possibility to turn malignant. They also have the possibility to grow so large that they would actually torse or twist off the blood supply to the ovary, which would be another issue. Here's a dermoid cyst seen on an x-ray. So you can see this one has a lot of calcifications in it, and you can actually make out the molars that those germ cell layers were able to produce. So fascinatingly disgusting, those dermoid cysts. Uterine fibroids are very common, and the uterus is made of a lot of smooth muscle. It's called the myometrium that offers our uterus the ability to contract. And so in that myometrium, if you have that muscular layer, and that muscular layer forms like an abnormal fibrous tumor collection, we refer to that as a leiomyoma, a fibroid, or a myoma. It's a benign smooth muscle tumor. It can often be multiple. Many people can have a fibroid type uterus where it's filled with different fibroids. Some can only have a singular one. These can vary greatly in size from, less than a centimeter to 20 or 30 centimeters. The growth of the fibroid is stimulated by estrogen, and lots of times during pregnancy and different times of high estrogen, you'll see significant fibroid tumor growth, and these can be very, very difficult for patients to live with. They can be removed. However, their odds are that they can grow back, and disruption of the myometrium, if the woman intends to carry a fetus in the future, could cause an increased chance of abruption of the uterus or a breaking apart of the uterus when having the pressure of pregnancy. Sometimes if the uterine fibroid is articulating or up against the endometrium, or that lining of the uterus that sloughs off during menses, it can actually cause irregular or dysfunctional uterine bleeding between periods. Here's an example of a uterus on ultrasound. This is not the prettiest ultrasound. So this right here, this dark black area, this is the bladder, this is the uterus, and you see hanging off the top of the uterus is this large mass. Again, if you're interested in going into ultrasound, don't let that picture deter you, because that's a very, very old image. Endometrial carcinoma is another malignancy of the female genital tract. This is an adenocarcinoma, or a carcinoma of glandular tissue. Our endometrium is that inner layer of the uterus. So our uterus has a perimetrium outer layer, a thick muscular myometrium, and then its inner layer is endometrium. And when we have a menstrual cycle, that endometrium is going to slough off and come out as menstrual blood. The rest of the month, after that process occurs, the rest of the month, that endometrium is going to build back up and thicken with this thick endometrial tissue. If that endometrial tissue begins to mutate and grow unusually, it can produce this adenocarcinoma. It is the most common invasive gynecologic neoplasm. It's usually going to affect our older female population, and it's very sensitive to higher levels of estrogen. So any female that for some reason has been on hormone replacement therapy, had high estrogen levels throughout their life, maybe started their menstrual cycle early and ended it late, any of these women that have had longer or higher exposure to estrogen are going to be at greater risk of endometrial cancer. Here's an example on an ultrasound of endometrial cancer. So here is the uterus. Here would be the endometrial canal. And usually the endometrial canal is nice and smooth and kind of bright. And here you see there's fluid components, there's many different tissue types, and this is indicative of an endometrial carcinoma. Here it is on CT, where you have a uterine mass that's invading the bladder. So you see the mass here, and you see the phalanges of that mass going into the bladder. Endometriosis is basically any ectopic endometrial tissue. So endometrial tissue that is not within the endometrial canal. And endometriosis can settle in anywhere. outside of the uterus. So some of the frequent places that endometrial tissue will be found is ovaries, uterine ligament, retrovaginal septum, pelvic peritoneum, and it can also settle in on the GI tract or bowels. And with endometriosis, that endometrial tissue, even if it's ectopic, is going to react with the hormones in the body just like the endometrial tissue within the uterus. And so every month that endometrial tissue will develop, get enriched, and then slough off. And as you can imagine, if that tissue is attached to your ovary or your bowel instead of your uterus, and it doesn't have a way to exit the body, that can cause a number of different symptoms, including discomfort and pain, and even lead to sterility. There's a number of different causal theories of how endometriosis occurs. Lots of times they believe that it actually occurs from reflux of that endometrial tissue or endometrial blood cells coming rather than exiting out of the body through the cervix and vagina, having a retrograde motion where it goes up higher into the uterus and out the fallopian tubes and enters into the peritoneum, where it can settle in on peritoneal organs and begin developing from there. Okay. Other beliefs feel that there's a transformation of multi-potential cells in the abdomen and pelvis, kind of like those germ cells have the ability to become many different things. Some people believe that there's just cells with potential to become different things, and they choose to become ectopic endometrial cells. Other causes of endometriosis can be implantation during surgery or a C-section delivery, and the spread of endometrial tissue through the bloodstream or lymphatic system. Here's an example of endometriosis on the colon, and you can see that actually this has caused some significant changes to the colon. It's lost some of its haustral shape, and this would then be acting like endometrial tissue, thickening, sloughing off, reacting to the hormones throughout the monthly cycle. Carcinoma of the cervix used to be one of the primary causes of death in females in the United States, but it's less common now, especially with the advanced medical care, the recommendations of common yearly or every other year pap smears, things like that. However, it is still a very common cancer in less developed countries because they are not getting their yearly pap smears if they're ever to get one, and different things like that. So tumor appears to be related to chronic irritation, infection, and poor hygiene. It can also be related to the HPV virus, and so the use of Gardasil vaccine is really going to probably have a significant effect on carcinoma of the cervix. Higher incidence would be from that HPV virus, which you'd pick up through sexual activity. So the more sexual partners, the younger sexual age, things like that are going to contribute to the probability of carcinoma of the cervix. Again, this can be detected through pap smears. Here's an example where this is a CT. Obviously, it's a contrast CT, so you have a contrast-filled bladder. Here is the cervix. It's rather enlarged and deviated to the patient's right, and you can see multiple different radial densities in this area, indicating something awry. Okay, that brings us to secondary sex organs of the female, and that would include our breasts. So breast cancer is a significant problem for the female population, as well as benign breast disease. Breast cancer is the most common malignancy among women between ages 44 and 50. It's the highest cause of cancer death in women. Although if it's identified early on in stage 1 where it is contained to a specific area with no movement beyond its contained area, then they have a 98% survival rate. Typical malignant tumors have poorly defined edges, irregular margins. They can be taller than they are wide, and they can have numerous fine linear strands or speculating radial strands coming out of the mass. They can also be identified with microcalcifications. So we use mammography, to evaluate for screening for breast cancer. These are older mammos, so so be patient with them. This is an indication of a breast cancer because of that spiculated appearance. Here is a magnified view of that area, and again, you notified that fibrous spiculated appearance that would make it suspicious for cancer. Benign breast disease is also fairly common, so you'll hear women talk about having fibrocystic diseases of the breasts, and these are benign conditions. They can also be referred to as a breast mouse. It occurs in about 20% of premenopausal or women within their normal reproductive years. It's usually bilateral, and they'll have cysts of varying sizes throughout the breast, also containing increased amount of fibrous tissue. Cyst sizes can change with the menstrual cycle because they are reactive to hormones. Fibroadenoma is the most common benign breast tumor. They're well-defined, smooth margins, round, oval, or gently lobulated. They can be identified on mammography, MRI, or on ultrasound. And I misspoke, it's actually the fibroadenoma that is referred to as the breast mouse. Here's an example of a fibroadenoma on a mammography exam, and you can see that it's well delineated and circumscribed. Imaging in pregnancy, there's a number of different things that can be imaged in the female pregnancy. Most of the time we think about it as a happy occasion, but sometimes things can go awry, and pregnancy, so imaging can play an important role in pregnancy. Years ago, and even when I was still in school, they would occasionally do something called pelviometry, where they'd actually image a pregnant patient near term to determine if their pelvis was large enough to allow for delivery of the fetus through the vaginal canal. That has really gone by the wayside because of our approach to try and use LARA to minimize use of radiation during pregnancy. So most of these imaging during pregnancy is going to occur with MRI or ultrasound because there are non-ionic radiation. Some of the things we can find on imaging in pregnancy are ectopic pregnancies, or pregnancies that are outside of the uterus. Trophoblastic disease, which is a pregnancy that goes awry and can actually become a cancer. We can look for female infertility, and usually, like with other imaging, ultrasound or MRI are modalities of choice because of the lack of ionizing radiation. For an ectopic pregnancy, it's any pregnancy that is not in an appropriate endometrial place. Ectopic pregnancies can be life-threatening if an ectopic pregnancy is in an area where there is high vascularity, and that pregnancy outgrows the size of its contained area, such as a certain area of the fallopian tube, and it can rupture the vessels as well, causing the mother to bleed to death. Ruptured ectopic pregnancies are not dangerous just anywhere in the pelvis. They have to be near highly vascular areas to cause that significant danger. These are responsible for up to 1/4 of maternal deaths. Diagnosis can be missed on the initial exam by a physician. They're also rather difficult to find sometimes on ultrasound. About 95% of ectopic pregnancies do occur within the fallopian tubes. Patients that have a history of endometriosis or pelvic inflammatory disease are more often likely to have these because of adhesions, those pathologies or scar tissue those pathologies would leave behind. HCG levels are lower with an ectopic pregnancy than a regular intrauterine pregnancy. Here's an ectopic pregnancy. Here you see the uterus over in this general region. Here you see what we call a decidual reaction, or a pregnancy type reaction with the embryo inside. And this is external to the uterus, therefore it is ectopic. Depending on its location in relationship to vasculature would be the determining factor on how dangerous this pregnancy is. Trophoblastic disease usually occurs when something in fertilization goes wrong. So perhaps one option is that you can have 2 sperm enter 1 ova, and the genetic material, the fetus or the embryo, ends up with an extra set of genetic material. There are other types of abnormal fertilizations that can produce a trophoblastic pregnancy. That's just one example. Trophoblastic pregnancies are also called hydatiform moles. And what happens is when this abnormal fertilization occurs, we end up with an abnormal embryo. And that abnormal embryo goes and it implants into the uterus. And when it implants into the uterus, there's usually some feedback that tells the placenta to grow and when to stop growing, and kind of monitor and control that. With these, because of the abnormal embryo, the cells that are going to produce the placenta grow wildly. Those are trophoblastic cells, therefore that's why they call this a trophoblastic disease. So what you end up with is a very abnormal or no fetus at all, and a very highly, rapidly growing trophoblastic mass, which can be referred to as a hydatiform mole. One of the things that this does is it can be very malignant and spread very quickly to other organs such as the liver. It can cause extreme elevations of HCG. It can cause a lot of sickness or illness in the patient, like hyperemesis or throwing up and nausea, vomiting, all of that. So the trophoblastic disease is very dangerous. They're usually identified on ultrasound. About half of these diseases can result in something called choriocarcinomas, where these are actually malignancies that are going to spread out to other organs. Now, sometimes these can occur even after a fetus has been born. So sometimes if placental tissue is left behind after a fetus has been born, or a spontaneous abortion, or also known as a miscarriage, occurs, sometimes some of that left behind tissue can start growing awry and create something called a choriocarcinoma, which is another type of trophoblastic disease. Here's an example of a very poor looking ultrasound, but it demonstrates a hydatiform mole. This area right here would be the bladder. This is the uterus, and this filled with this hydatiform mole, which is tissue separated by small grape seed-like areas, is indicative of a hydatiform mole, especially with a positive pregnancy test and rapidly rising HCG levels. So what is the most common cause of cancer deaths in women? It's going to be breast cancer. What is the most common germ cell tumor in women? This is going to be your dermoid cyst. Thank you so much for sticking with me through this lecture. Only one more to go next week. I hope you have a great week, and we'll see you all soon.